many procedures involve a lot of creativity. And there's certainly many of the procedures that I do, whether it be fracture work or, doing, joint replacements, things like that. There's a lot of creativity there.
Welcome back to another episode of the Making Magic podcast. I'm Shaun J., your host, and I'm a professional magician, speaker, and 3D designer. And this is all about inspiring conversations with the movers, the shakers, the visionaries, and the makers, the wizards behind the curtain that make the magic for you. Now, if this is your first time tuning into the show, thank you so much for doing so. It really does mean a lot to me because I put a lot of hard work into each and every one of these episodes. Whether you're listening to the sound of my voice on any one of the popular podcast apps or on YouTube, hopefully you'll decide, if you're a podcast type of person, that you'll follow the show. Follow me along for the ride and leave a healthy review of the show. And if you're here on YouTube, feel free to give this show a thumbs up, comment below, turn on the notification bell, and subscribe. You guys know what to do because I'm all about getting your creative gears turning, and that's what this show is all about. Whether you feel like you're stuck with a certain thought pattern and you want to break out of your current thought pattern, if you feel boxed in and trying to be inspired to think in new ways, well, I've got some of the world's most creative people that are sharing their process with you on this show. So I hope you decide to join me on the journey, and I'll be releasing episodes like every week now. So I hope you guys are enjoying this stuff. So with all that being said, let's learn a little bit more about our next guest. Hey, Dr. Bruce Wolock, thank you so much for joining us. Welcome to the Making Magic podcast.
Yeah, thanks, Shaun. I really appreciate it. And I'm honored for you to have me as a guest.
Awesome. Yes, this is going to be a great chat. We're going to dive deep into learning a little bit more about you and what you do. And hopefully by learning these things, it's going to inspire people to get their creative gears turning. Because even though you're not a prop maker and you're not a performer or anything, you do things that many people would be considered magic or magical. So I saw your resume. It's pretty extensive. You have an insane amount of training. But for the viewers and listeners, I'll let you just give a basic intro of who you are and what you're about. So go for it.
Sure. Yeah. Well, I mean, I guess in terms of my training and how I got to where I am, I started with college at Johns Hopkins, and then majored in biomedical engineering. And then from there, I went on to medical school at Case Western Reserve in Cleveland, Ohio. And then I came back to Hopkins for what's called a residency in orthopedics, which is basically 5 years of kind of training for, going into the field that I've eventually in practice now. And then after that, I did 2 fellowships. So that's extra training. And one of them was in sports medicine. And then I did that here locally in Baltimore. And then the second was in hand surgery and upper extremity surgery. And that was at Massachusetts General Hospital in Boston. And then after that, I came back to Baltimore and I actually ran in private practice here in Baltimore. I did run the hand clinic at Hopkins for about 5 years at the beginning, and then have been strictly in private practice really since I came back to Baltimore. And I guess, I've been involved in, lots of different types of surgeries, arm transplant surgeries with part of the arm transplant team at Hopkins. That's probably been one of the highlights of my career.
Yeah. I mean, that right there is magical. Taking someone who's missing a limb and then magically giving them back that limb and that movement and motion. That's amazing. So thank you for giving us that intro. So now we have some context here. So I always like to start off each episode with a story. And so in your case, Dr. Wolock, I'd like you to share with us your story on how you originally got into orthopedic surgery. And this could be good or bad, and funny stories are always welcome.
Sure. Yeah. So when I was in college, as I mentioned, I was a biomedical engineer. So it was kind of really not a typical path to go to medical school or become a doctor.
Right.
But during college, during the summers, I worked down at a biomedical engineering lab at the medical school, and they were doing what's called auditory neurophysiology research, or basically research into how the how signals from the ear go to the brain and how they're processed. And while I worked there for 2 summers, and while there, really my plan was to probably go on and do some research into some type of biomedical engineering. And I remember talking to the docs, the PhDs, really, the physicians there, but most of them were PhDs and not medical doctors. And they said to me several times, if you want to get grants, which is basically the lifeblood of research, they said it's a lot easier to get grants with an MD than with a PhD. So at that point, I'd been thinking about possibly going to med school, and that kind of really pushed me in that direction. And so I basically, after doing a couple of years of that, you need to apply in their 3rd year of college. I basically decided I better apply. Let me apply to some medical schools, which I did. And I think that's there are actually some really kind of nutty stories about certainly med school interviews. I mean, I this really wasn't kind of my forte in terms of I wasn't planning on this at all. And so what I did is I went on one interview down at Baylor, down in Texas, and I guess for some reason I'd forgotten my nice dress shoes. These are in-person interviews, and they count for a lot. So all I had was my tennis shoes, and so I go for my interviews down there. I didn't even think of like going to a store and buying a nice pair of shoes. I mean, I guess I just wasn't raised that way. My dad, was fairly frugal, and it was like there wasn't the kind of thing you just go out and just spend money. And so I'm at this interview, and I have these tennis shoes on, and my interview is with a female psychiatrist. Okay. And I'm just like thinking to myself, oh my God, this woman is like analyzing me. Here it is. I have tennis shoes on at this fancy interview with my suit coat. And to make matters worse, I guess when I shaved that morning, I'd cut myself. And all of a sudden, in the middle of the interview, I touched my face, and there's blood there. And I guess I'd started bleeding right in this middle of this interview.
Oh no! So
that was one crazy story. Another one was when I interviewed here at University of Maryland. One of the docs, he said to me, "How much do you think the average person makes?" And I guess at that time I thought, well, the average salary of people in the country was probably, I don't know, $25,000, $30,000 a year.
Okay.
And after that, he said something to me, "You've led a very sheltered life." And afterwards, I'm thinking, well, he probably meant how much does the average physician or doctor make, which was probably at that time much more.
Right.
So either way, actually, the funny part about that is that he clearly knew I wasn't going into it for the money.
Right.
And actually,
yeah.
I got accepted to that after that one pretty quickly. So that's kind of how I kind of got to the med school thing. And then as far as orthopedics is concerned, when you go to med school, the first 2 years is all bookwork and cadavers and things like that. But the last 2 years is what they call rotations, where you go through the different specialties and you spend, weeks or months doing certain rotations, internal medicine, OBGYN, surgery with the subspecialties, pediatrics. So my first rotation, I really don't want to say which one it was, but it was like 2 or 3 months, and I'm doing this rotation, and I'm thinking, okay, maybe I could see myself doing this in the future. I'll see. Let me see what my rest of my rotations are. The second rotation was surgery, and one of my first weeks of doing surgery was a subspecialty in orthopedic surgery. And as soon as I did that, I shook my head and I said, oh my God, this is like banging your head against the wall, and you don't know how much it hurts until you stop banging it. That's what the first rotation was like. It was just literally painful compared to what the orthopedic rotation was like. It was fun. It was positive. It was just, I knew right then, I said, this is probably what I'm going to do. And this was the beginning of my second rotation. And sure enough, each rotation I did after that, nothing compared. So that's kind of how I got into orthopedic surgery, and how I kind of, got into the whole field.
I thought that was funny, actually, going back to your first story about something, sitting there with the psychologist, and then, you're looking a certain way, and then And then she was probably making all kinds of assumptions about who you were, with the shoes and then the face. And then it was just like, can you imagine what her dialogue was? This guy must be,
Yeah. I mean, I got to say, I was, I was a little bit more than a little bit nervous, and I'm just like thinking, oh my God, this woman, is just, didn't matter what sex she was, but just a psychiatrist. And I'm just thinking, I'm sure they're analyzing something about what has happened here. Not only do I bleed, I had my Adidas on. It's like, oh my God, it was just crazy.
Yeah. So, well, that's proof that everybody makes assumptions based upon what they see really quick, and it doesn't. Most of the times, it's not true.
Right. And you know what? To make matters better, I eventually got accepted to that med school too. So it didn't hurt matters much.
There you go. Well, I'm glad it all worked out, and it didn't hamper anything too much. Okay. What was, I don't know if you already answered this, but what was the reason why you went into that field?
So, so orthopedics is just really in general, a very positive field, in my opinion. There's, not a lot of people have really horrible, serious illnesses. It's not like I'm an oncologist where I'm dealing with people who have these life-threatening diseases, cardiac surgery, vascular surgery, where these people just have these horrible, you're constantly dealing with people that are really very sick. It's quite the opposite in general, unless you go into orthopedic oncology. You're really, you're dealing with very motivated patients. In other words, people are motivated to get better. So it's a very positive field. People want to get better in general. There's a number of other things. Surgery in general is a very creative thing. Every surgical procedure, you do is a creative thing.
Yes.
Particularly orthopedics, but many other specialties, plastic surgery, I'm sure is like that too, where literally you're creating something. Every surgery you do, not every, but a lot of them, you're creating something out of, where something didn't exist or wasn't doing well. Whether you do a joint, or joint replacement, that's, creating a new joint from a joint that doesn't work.
Yeah.
Certainly a carpal tunnel release, that's not terribly creative, but there's many procedures I do that are quite creative. So if you like to be creative and work with your hands, which I do, it's a great field. I've always liked to work with my hands. I remember as a kid growing up, my friends and I, we would all get together and we would, build these, plastic models with the glue and everything. And we would all get together and, build things, or whether it was these airplanes, the little airplanes that you fly around. We'd get together, we'd build those and put the motors on them and, the engines, and fly those around. So I was always doing that. Chemistry sets, again, just kind of playing with your hands. And so I've always been kind of somebody who's creative. I still do that, not even with surgery. I do, a lot of bonsai, which again it's a very creative thing. You're dealing with kind of these miniature trees, and you're dealing with it's like a living sculpture kind of thing. So I think that's really what it was, a natural for me. I even in shop when I was in high school, where we would do woodworking, things like that. I built lots of things in shop, and I really enjoyed it. In fact, I still have a few of the things that are created to this day. We still use every once in a while. So it's a positive, creative field. And so if you like to work with your hands, if you like to deal with people and make people better, it's a great field.
Yes, and the people that get into that field have to be very, very sure about it, because it also requires a ton of schooling, which can be seen on your resume, right?
Yeah, it definitely does. It's not like being a carpenter. A carpenter, we deal with biology in addition to the carpentry. So in other words, we're not just like, cutting bones and things like that. We're actually dealing with the healing and the biology of that. It does take a lot of, unfortunately, it does take a lot of schooling and things like that. So we're not just glorified carpenters, that's for sure.
Yeah. It's something that requires serious effort, and people really got to be into it. But as you said, it's a great thing to get into if people enjoy working with their hands and they enjoy biology and those things. So knowing what you know right now, what would you wish you could have told yourself earlier on, maybe in your career, that would have prevented you from making the mistakes that maybe happened along the way? Because I'm sure not everything goes according to plan, and sometimes it's just not perfect.
Yeah, no, I think that everybody makes mistakes. I got to say, I've been pretty satisfied. I don't have a lot of regrets. I've had a pretty rewarding career. I'm kind of maybe towards the tail end of my career, but I feel good. I feel healthy. I have no plans to retire anytime soon. I would say probably if I were to say I had one regret or one mistake is possibly maybe not work quite so hard early on and maybe spent more time with my family and kids. Just because, the harder you work, the less time you have for your family. Professionally, no question. I've had complications and mistakes there and, failures, and maybe we can get into that, a little bit later in the interview. But I think that's probably my biggest regret. The funny thing is now sometimes my wife will say to me, why are you doing that? And I'd say, trying to make up for lost time. In other words, spending time with my kids or doing things with them. Trying to make up for lost time. I know it's not specific to my career, but I guess it's being a person, rather than my professional career, maybe my personal life.
Well, yeah, it's all part of personal and professional development, just like prioritizing your time and so it all falls within that.
Yeah, back in the day, I prioritized it probably too much in the terms of, my professional career. People would say to me early on, how did you get so busy? And the answer is, because I never said no. If somebody said, hey, can you do this? And yes. Yeah. I was always available.
Got it. So you were like a yes man.
I was. You learn early on. You only have to say no once or twice before people move on and send those referrals elsewhere. So that, it frustrates them to get a no.
So yeah, I guess over time, from being a yes man so long, you got perhaps a little bit more adept at learning the right times to say no, hopefully.
Yeah. I've tried to get better and better at it. I cut my schedule back a little bit. But I currently have a secretary who she's like the way I used to be, doesn't like to say no ever. And so it's funny that we're taping this on Halloween because today I got into the office and she had 2 T-shirts, and it's a saying from a old movie. I think it was The Sandlot, and basically one of the T-shirts said, "You're killing me, Smalls," because I always say, "You're killing me, Kelly." And then my T-shirt said that. Her T-shirt was Smalls, and so that was our Halloween costume for today because it's just. She doesn't like to say no, because it's just, she likes to kind of keep me busy.
Gotcha. Yeah. If she's busy, then you're busy, and she probably likes to be busy, I guess.
Yeah, exactly. So.
Okay. What about in your field then? Are there any recent discoveries that you've made in the field of orthopedic that kind of are getting you excited this year or in the upcoming years, like anything on the cusp of development?
Yeah. So I think, discovery wise, I think, and this isn't specifically my discovery, but what would go along with that is I've been privileged to be a part of the Johns Hopkins arm transplant team. And I guess we've been with this team for about 10 years, maybe 12 years. And we've basically done, occasional arm transplants. And I think that's really been quite rewarding and really quite interesting. And over the 12 years we've done, I guess, transplanted 5 arms on 3 patients. So that's really been quite a challenge when we do them, and really just, really very interesting and rewarding, not only for us, but also for the patients. We have, I don't know how detailed you want me to get into it, but it's a large team of highly trained surgeons, microsurgeons, orthopedic surgeons, plastic surgeons, mostly hand surgeons. And, we basically have intermittent meetings down at Hopkins. It was initially run by Dr. Andy Lee, and then now it's been taken over by Jamie Shores at Hopkins. And basically, we transplant arms onto patients in general, most of them have no arms. Yeah. So they're bilateral or both arms are gone. One patient had no arms or legs. And so that's, to me, well, any of these are life-changing when you have no arms, but have no arms or legs. He couldn't walk. He couldn't do anything for himself. Those two cases, the bilateral, were both veterans, I think Afghanistan or Iraq, IED explosions. And so the guy with no arms or legs, I mean, he actually, after surgery, he was able to walk because he could put prostheses on his legs. So not only could we use his arms, but he could also walk because he could put prostheses on his legs. So that's an incredible life-changing thing. And then we did another one bilateral, also, two arms, and then one was a unilateral single arm. So that's really quite an experience, I think, and I think quite a amazing technological accomplishment.
It's quite the thing. I mean, I thankfully never had to have any of that type of assistive surgery in my life, but when you think about it, is it just like you said, it was a team, so it's not just one guy; it's a whole bunch of people in a room over. Yeah. Each one is assigned a different task, and they're over this person.
They're getting out the nerves, the arteries, the muscles. They're preparing the bone. Well, because we have through preoperative planning, we have a pretty good idea how long we want the bones to be for the recipient as well as the donor. Mm-hmm. And then there's two more teams, and each team consists of 4 people. So there's probably a good 16 people in this room, and maybe more. And then the other 2 teams are preparing the arms for the recipient arms for the donor arms. And then once everybody's all ready and got everything, particularly on the donor arms, I tended to work on the recipient arms rather. The donor arms have tons of scar there from explosions and then from their subsequent surgeries we had to literally get out the nerves, arteries, veins, things like that, tag them with little tags so we know what's what, and so we can hook up the appropriate things to the appropriate things. I mean, my team did that. My team, I work with some really unbelievably talented surgeons in general. Jim Higgins, Ryan Katz were both really talented hand surgeons at the Curtis Hand Center. And we basically worked on the donor arm, the recipient arms together. And then once the donors were ready, they'd bring them in. And then what we do is the first thing we do is the bony work. In other words, plates and screws on the bones, you need bony stability. And then after the bony stability, then you do the muscles and the ligaments. That's the next to go. And then after that, it's the nerves and the arteries. And so I tended to work on kind of the preparation of my personal part of this. And again, this is a 12-hour procedure or more. My personal, I'm a part of this huge team, as you know. My personal part is I would tend to work at the beginning, to get the preparation work together. They bring in the recipient arm. We do plates and screws, and it could be at the arm level, at the shoulder level. In other words, some of the transplants we did were at the level of the humerus, like in this area here. Some of them were actually at the forearm level, so right in here. As you might imagine, a little more difficult here because there's 2 bones to put together, whereas here it's just 1 bone to put together. Okay. So we did the transplants, or in various places on different patients. And then once the bony, you achieve bony stability, then we would do the muscles and the ligaments and the tendons. And then at that point, I would let the micro team take over, and then they would do the nerves and the arteries and things like that. So it's quite an accomplishment. I mean, as I said, it takes a long time, a lot of micro work. It's a long procedure. Here's actually, I don't know if you want to see this is a photo of the team from one of the surgeries we did. Sure. So you can see, I can't remember, 15, 16 surgeons there. And again, it was at this point, it was run by, go ahead.
I was just going to say, it looks like more than 13.
Yeah, it could be. There's a lot of people there. Yeah, it was run by a guy named Andy Lee, who's right here. He was the head of the transplant program at that time. Yeah. Jamie Shores is now he runs it. Jim Higgins is here. He was very instrumental in this program, and so they're all really talented people and incredibly smart.
Yeah, yeah. I counted. I believe that was 18 people in that.
Yeah. It's a big team. So I'm a part of a big team, but it was it's really very there's not a ton of those that are done throughout the world. So it was pretty. In my opinion, it was an honor to be included, but also it was just really. So many things I do these days are reasonably routine. There's nothing about an arm transplant that's routine. I mean, we did tons of training for these cases in terms of we would have meetings just to go over the theory and just what we were going to do, where we're going to cut the bone, how long the donor arm is going to be, how long the recipient arm is going to be, how are we going to where are we going to put the plates and screws, what are we going to do with the nerves and arteries? How about the skin, or because you need the huge skin flaps. And we even did cadaver dissections a few times, just as practice sessions for these people. And then, you don't know when the recipient's going to be available. And, the recipient has to be basically an organ donor. And so you got to wait. These cases, these cases tend to go, in the middle of the night. I feel like we frequently started these cases around midnight. And actually, the first one we did, that's if you want a funny story, that's a reasonably good story.
Sure, let's do it.
We got a call about it. I can't remember. It was sometime it could have been the day before, the night before, that they think they have a donor. They're not sure. And basically you have to travel to where the donor was. I think the donor was in Pittsburgh. And so there's a team. I wasn't a part of the team that traveled to Pittsburgh, but basically, you take the arms after they harvest various organs, and then they take the arms. I think the heart and lungs are the last to be harvested. And then they would put them on ice and they'd bring them to Baltimore. And anyway, I think they wanted us there around midnight on a Saturday night. We all went down to Hopkins to be ready. And I think we probably didn't start till like 2 a.m. But we had a dinner party that evening. And so I remember with my wife having dinner guests over that evening. And I said to them, look, I'm going to stay for an hour or two. But I said, probably around 9 or 10, I'm going to go in bed and try to take a short nap before I have to run down to Hopkins, which I did. I didn't sleep very well. But anyway, I took a short nap, went down there. Anyway, the next night, I had tickets to see Dave Matthews downtown in Baltimore. Okay. They were like, I'd been really looking forward to it. It's a small arena. I had good seats. There's not a bad seat in the house. My wife said, "You're not going to this, are you?" Because I'd been basically up most of the night. And I said, "Yeah, we're going." So we went to the concert, and I think after about an hour and a half, I was just starting to doze in my seat, and it was just painful. So I had to leave early. But anyway, I did go to the concert.
You went to the concert. Was it, you said, the same night that you were supposed to do that surgery?
No, it was the night after. We did the transplant.
Okay.
So we had the dinner party. I did the transplant at midnight, whatever. The next morning, I go home. I literally, I got dressed. I had to go straight to the office to see patients in the office, and then got home. And then the next evening, we had tickets. And she just said to me, "We're not going to this concert." And I said, "Yeah, let's go." I said, I can't. So we went. So it was good. It was worth it.
Well, you're a real machine then. I mean, I would have been exhausted after doing something like that at that hour. And then I would have been like, "No, I'm staying back. I don't want to go."
Yeah. I mean, that's kind of, unfortunately, that's what you get trained for in your residency. You just spend a lot of time awake. And I think that's half the training of the residency is being ready to be awake. I remember in fellowship in Boston, we were, when we were, putting fingers back on all the time. I remember, my longest procedure there that I personally did was 16 hours, putting on multiple fingers on a hand. Now I did get a break during that 16 hours, but my longest time under the microscope, no breaks, nothing, was 12 hours. That's a long time. I mean, with the microscope, using microforceps, that's unbelievably, I never would even think of doing that now. And that's why this arm transplant team, the team, is so good, because you have all these incredibly trained, incredibly talented people there. So like, if you get tired, there's somebody else right there ready to take over.
Nice. Yeah. Yeah. It makes me think, like, when you're reattaching these things, you said the microsurgeries with the arteries and the nerves and the vessels, it kind of reminds me of like soldering, right? Is it kind of similar to like a soldering iron? You prepare the end and then you somehow use something to join them together, or?
So I wish it were so simple, because although nerves are getting closer to that, they do have this glue that they can use to put together, put nerves together. What's called fibrin glue. Fibrin is one of these things the body uses to make blood clots with. So they do use that for some nerve repairs. But back when we were doing that, certainly the initial ones, these were all sutures, so stitches. So the stitches are what we call, they're tiny. They're like finer than a human hair. And as I said, you're doing it under a microscope, these really fine instruments. And again, I wasn't, although I did plenty of microsurgery, at that point, there were people there who were they did tons of microsurgery. So they were the people that were doing that. Mainly a lot of the plastic surgery or plastic hand surgeons were doing the micro stuff during the arm transplant procedures. But those are stitches. And so every vessel, you're putting in 8, 10, 12 stitches, every single vessel. So it's a pretty tedious job. And same with the nerves, weren't quite so many stitches, but it's very slow and meticulous and really tedious work. And you're sewing, some of the vessels are relatively big, like in the upper arm area here, those are reasonably sized vessels. But as you get, further down into the forearm, some of them are small vessels. And certainly like in the hand, like when I mentioned I was doing like finger replants, or basically putting on fingers back in my fellowship and even early on in practice, those are tiny vessels. We're talking 2 millimeter vessels. And so the sutures are finer than, as I said, finer than a human hair. So that does take it's very tedious, quite a bit of skill and quite a bit of concentration.
That I could imagine, just with my experience soldering and my experience sewing, which I'm not great at. It's kind of like that. You have these micro tools under the microscope, and you're very slowly, just right.
Yeah, and they are definitely coming out with, as I mentioned, the fibrin glue, which is helps with nerve repairs.
That's amazing.
And they are coming out with these little vascular clips, where these almost like these little cylinders that you can put the each end of the vessel on, and it'll help to keep the vessels patent, and basically you can use that. So they're definitely coming out with things like that, so that you don't have to do it's not so tedious. You don't have to do quite so much suturing and things like that. So it does make things a little bit easier.
Okay. No, that's fantastic. And what about so there's many different ways of doing this, and there's many different tools, and there's emerging technology. And I think it's pretty obvious to the viewers and the listeners at this point that surgeons have to be creative, and you can't just, I'm sure there's things that work according to textbook, but then there's things where you need to use times where you need to instantly think on your feet and go, wait a minute, that method didn't work. So now let's try this, or maybe we got to approach it from this angle, or put it, insert the suture here rather than there. Am I correct with saying that surgeons, and especially doing what you do, would take a lot of creativity?
Yeah, no, I agree. You could make an argument that certainly many procedures involve a lot of creativity. And there's certainly many of the procedures that I do, whether it be fracture work or, doing, joint replacements, things like that. There's a lot of creativity there. I remember asking one of my mentors about, doing a procedure. It's called a thumb basal joint arthroplasty. And basically what that is, for people that have arthritis kind of in this area here, very common area to have arthritis, more common in women than men. But as people get older, they tend to get arthritis in that area. And there's a pretty common procedure where you take out the arthritic part of the bone here, and you take a piece of a tendon and weave it through the bone and put it into space so the bones don't rub together anymore. I remember talking to him about how it was, you're supposed to do it, and the articles, and he looked at me, he said, you do it however works for you. He says, it's like your signature. He said, everybody's signature is different, and everybody's procedure is different. And it took me a while to really understand exactly what he said, but I, it didn't take too long, because I realized that he's right. Everything you do, and honestly, you could say every case you do is your signature. because again, some simple surgeries, at least for me, trigger finger releases, carpal tunnels. Well, yeah, that's not so creative, but something like joint replacements and what I just mentioned is a type of a joint replacement. We just don't use, we use biologic tissue, namely your own tissue, rather than in general, metal or plastic or anything like that, which many joint replacements are, like shoulder replacements, elbow replacements, or metal and plastic, or hip and knee replacements, same thing. But they're all creative. You have to make cuts in the bone in a perfect way, or if they're not so perfect, then you have to adjust your prosthesis. And so, there's a lot of creativity and a lot of mental work there. When I was younger, I never really realized how much how much brain work there is in doing this. I guess when you're young, it's so easy to get through an 8 or 12 or 10 or 12 hour day and just say, okay, that was pretty easy. As you get older, you realize it's not so easy. And at the end of the day, I don't know if you know, but the brain uses 20% of your energy, which is an incredible amount when you think about it. I mean, it's not a muscle but it's just generating, it's just taking up a huge amount of your energy. And at the end of a long surgery day, right now, 8, 10, 12 hours. I mean, I can go 7:30 to 6:30, that's not uncommon for me. Well, that's 11 hours of surgery. At the end of a day like that now, I'm beat.
Exhausted. Yeah.
And if I don't, and unfortunately I don't take time for lunch usually, I'm just kind of snacking during the day. So at the end of a day like that, I'm starved.
Tired and hungry.
Yes, exactly. Yeah. Yeah. So there's a lot of creativity. There's no question that there are a lot of inventions that, people make and invent. And orthopedic surgeons are really very big on that, inventing different things, from hip replacements, knee replacements, arm, elbow replacements, all things like that. So it's a very, inventive, creative field.
And I think that people can take this just what I'm hearing, how to apply this to the real world. Basically, the concept here is like, even for surgeons like you that go to school for all this amount of time, you're trained with all this procedural stuff. We need to realize that there will be times where we have to go outside of that, and we can't follow the script every single time. We can have a framework that we can work with, right? But there's times where things just happen that are out of our control. And then it's like, boom, got to think on your feet, and you got to realize, well, wait a second, that wasn't in the book. That may not have been in the program, but how am I going to get from point A to point B? And then you have to be open to that.
Absolutely. Yeah. I've been, luckily, I try to keep situations like that to a minimum.
Right.
So, I mean, some may say I'm a bit obsessed with detail before I do a procedure, to try to minimize those times, because there are times when surgery can just be terrifying. Luckily, that's pretty unusual. I'd say it's very unusual. Because like you said, you're in the middle of doing something, things didn't go according to plan. And it's like, wow, what is plan B here? Luckily, as I said, that's pretty rare. And most problems, if I get into like a minor complication or a minor problem, I've dealt with it before and I know a way out of it. And then if something hits you and all of a sudden you think, okay, I got to think this through, but I got to think this through fast, because you got somebody who's asleep on the table. You don't have an hour to let's just have them go to sleep. I'm going to go look it up in the books,
right,
and see what I can figure out. I would never do that. So anyway, it can be very challenging sometimes.
Catch a coffee break. There's a sleep. They won't remember how long I took.
Yeah. No, I mean, quite honestly, I know surgeons that have done that before, but I don't know anybody currently in practice that does that. But I know when I was younger, there were surgeons who literally would take a break for lunch. They'd go for an hour for lunch. Patients still asleep on the table.
Oh, really?
So, yeah, like I said, I don't know anybody that does that now. I'm not sure that that would be tolerated anymore. The old days were very different.
Yeah. They probably wouldn't be in practice for long, keeping that routine up.
Yeah. No, you're right.
Wow. Okay. What about, are there any surgery methods or ways of doing things that you're excited about learning this year? Well, this year is almost over at the time that we're recording this, but in the near future.
Yeah. I mean, every year, there's we go to meetings, and one of the big meetings I go to is what's called the American Society for Surgery of Hand, otherwise known as the Hand Society. And there's a couple. There's another American Society for Hand Surgery. But either way, yeah, I tend to try to go there, and I always kind of pick up a few things that I think are really interesting. At this point in my career, there's not a ton that's new to me, but I feel like every meeting I pick up one or two tips. And yeah, I think one of the things is, we're using ultrasound more and more in hand surgery and orthopedic surgery. And I am kind of interested in learning a little bit more about that. I have been using it some. You can use that for to help guide injections. You can also use it to evaluate masses or tumors that you see in the office. And sometimes I can do it instead of like getting an MRI, which is a more expensive study. So yeah, that's one thing. Typically, if I'll see somebody with a mass in the hand or arm, and I'm not 100% sure what it is, I'd say 90% of things I see, 95% sure that I know what it is before I even get into further study. Frequently, I don't get any more studies. But sometimes if I'm pretty sure, I'll just say, hey, let's just get an ultrasound, and I'll bring them in, the ultrasound machine in, and I'll look at it, the ultrasound, and then I can say this is a cyst or this is not a cyst. And we can get it out. We can get an MRI. We can not get the MRI. So that's one thing. I also use it like for certain injections, particularly for carpal tunnel syndrome. Surgery is obviously a reasonable option for that. But before we do surgery, people use splints and anti-inflammatory medications. Sure. But another thing is that you can give them a steroid injection in the carpal tunnel. Well, if so the carpal tunnel is a reasonably small space. And if you give the shot in the wrong place and you hit the nerve, it's like putting your hand in a socket. That hurts.
Yes.
And so I'll use the ultrasound frequently to find the nerve. And that way I know exactly where the nerve is, and then I'll give the needle. I'll know I'm near the nerve, which is what I want to do, but I don't want to be in the nerve. And so I've been using that a bit more for my carpal tunnel injections.
Ooh. Yeah, I know. I've heard about steroid injections and those things, and those usually, right, if it works, it helps reduce the pain, but the actual act of doing it generally kind of hurts a lot, doesn't it?
Yeah, some of the needles are tough. Look, the needles in the palm, the hand is very, very sensitive. Yeah. So palmar injections tend to hurt a lot. Other areas of the body usually aren't quite as highly innervated or not as many nerve endings. And so like shoulder injections, top of the hand, elbow, sure, it's a needle, but it's not a horrible needle. Like, when you get your flu shot or, if you get a vaccine shot or whatever, in your upper arm, those shots, sure, it's a needle, but it's not a terrible needle. And same with shoulder injections. But if you get one in your hand, yeah, they tend to hurt. The palm, same thing with the foot, the sole of the foot, those hurt, highly innervated areas.
Yep.
So.
Yep. Okay. Now I'd like to get to one of my favorite questions, which always brings out something crazy. And most of my guests, have you ever had a surgical fail or had this experience where it was just like this big thing where you thought it was going right and then it just kind of blew up in your face and it was just a big disaster? And of course you can say this in the most politically correct way without naming names. I know the medical stuff and HIPAA laws and stuff, but if there's any way that you can think of or draw out one of these crazy epic fail stories, that would be great.
Yeah. I can think of a few things. One is one of these terrifying cases where earlier on in my career, someone had what seemed like what's called a lump in their underarm area, that was called the axilla. Mm-hmm. And I figured, okay, I'm an arm surgeon, I can do this. I take out masses and lumps. Didn't think it was I don't tend to take out things that I think are possibly malignant. I would refer those to an orthopedic oncologist. Sure. Because the person who does the initial biopsy is the one that should do the final surgery for those cases. But luckily, most things I do are really not, malignant. And I'm pretty sure they're benign. But this one, I figured, I thought it was what's called a hemangioma, which is just a benign blood vessel tumor. And so I get in there and I realize this hemangioma or this tumor is completely wrapped around the arteries and the nerves in the underarm area. And most of the surgeries I do are under tourniquet, meaning there's a blood pressure cuff in the arm. And so there's no bleeding during the procedure at all. Okay, that we put the blood pressure cuff up, we can see everything perfectly, and then at the end of the procedure, we let the blood pressure cuff down and get any bleeding under control that we have, because it's such a highly constrained and under such a great environment, meaning no bleeding. You usually at the end of the procedure, if you've been careful, there's really minimal bleeding anyway.
Okay.
It's because you cauterize blood vessels, or you tie them off, or do whatever you need to do, or you just avoid them completely, or pull them out of the way, or retract them. With this procedure, there was no tourniquet. And so I get in there and I realize this is, there's no way I can do this by myself. It's like, I was like thinking, I don't know what to do. Luckily, I had a friend who was a vascular surgeon, and it was in his this is in his wheelhouse. And so I actually had the nurses call him, and luckily he wasn't that far away, and he came and kind of, helped me finish up the procedure. So luckily it didn't end up be a failure, but it was definitely I could put that under, for me, it was terrifying to be in a case like that. The alternative would be just to close it up and say, hey, you need to go see someone else.
Yeah.
But I didn't want to be in one of these cases where I got into uncontrollable bleeding and possibly, have that kind of issue. That wasn't going to be in the cards or in the table for me. Another one I can think of, maybe not quite so terrifying, but still, and I really don't take complications well at all. I guess no surgeon does. But This is a case which I was handed down from one of my partners who had, somebody had a broken wrist, and he had put what's called an external fixator on. So that's something where you have, pins, in the arm here. Mm-hmm. You have pins in the forearm, pins in the hand, pins in the forearm, a bar that connects them. He was using that to stabilize the fracture.
Okay.
And so, he sends it to me a couple of weeks later, and I can see the fracture position is just really not good at all. And he says, hey, what do you think? And I said, yeah, I think you need to take that fixator off and put a plate and screws on. And so he says, okay, you want to do it? So I said, sure, I'll take care of it for you. He was kind of a general orthopedic guy, whereas I'm really a specialist, hand specialist. So I said, sure, I'll take it on. So I take the fixator off, and I'm getting ready to put the plate and screws on. I figure, let me just manipulate the fracture and see if maybe I can just kind of do it without a plate and screws and just put some pins in it, manipulate in place, put some pins in it. And sure enough, I start manipulating it, and I break the radius bone. So in other words, here's a model here.
Oh, okay.
So they have pinholes here. I break the shaft. It's already broken down here, which is what I was going to fix.
Ooh.
Now I break the shaft right here, and right through one of the pinholes, because the bone's weak from where the pins had gone through the bone. And so that is really, then now that ruined my day, possibly my month. And so at that point, I'm thinking, what am I going to do? Well, now they've got an unstable, completely forearm bone, plus they have the fracture down here. So I'm thinking I have to put a plate and screws here, and I also have to fix the wrist. So at that point, I left the OR actually at that point, and I went to talk to the family, and I said, look, this is what happened. This is what I think we need to do. Basically, it's a complication, but I want to tell you, this is what I think I should do. I don't want to wake them up and then bring them back another time. So do you give me permission to do that? And of course they said yes. And so I plated, plated the radius bone, where the fracture was here. I took care of the fracture here, and eventually the patient did fine. But I guess that could be go under many of the headings in this talk where, pretty scary, thinking on your feet, complication, really not things don't always going according to plan, having a good plan B and a backup plan.
Wow. So this bone, after it broke, was it sticking out at an angle, or it wasn't sticking out, but I just broken it because it's weak. When you have an area where the screws have been, it's big screws. I actually have one of those devices here. Oh,
I can show you.
Do tell, do share.
It's this is kind of the device, and basically what it is if you put it on the arm, these two of the pins go in here, two of the pins go in the forearm, And so you can see these pins are decent size.
Oh yeah.
So they'll weaken the bone. And so if you're pushing the bone real hard, which unfortunately is what I was doing, I broke the bone. And so that was that was not a desirable outcome. But I mean, the good thing is the patient eventually did well, and honestly, it really taught me one thing, is that if you ever have a complication, the most important thing is being honest with the patient, being honest with the family. Telling them. I guess I have another kind of case that was just really scary. It was I was doing what's called an endoscopic carpal tunnel release.
Okay,
and that's a case where you just make a small incision here. Yeah, you do a carpal tunnel release just through a little scope, and it goes up under the carpal tunnel, and you release the ligament, the transverse carpal ligament, with a little scope. So so routine procedure for me. I probably do 100 a year. I've been doing these since 1992. So I've done thousands of these.
Okay,
and I'm doing one, and the anesthesiologist, really, the patient's not really sleeping very well. And while I'm doing it, patient's moving their arm back and forth and back and forth. And I have the scope in his hand, and there's things that I don't want to cut within millimeters of the knife blade. And it's not like I have an open, cut where I can see well. This knife blade is in there, and if he's moving, I can't see.
Why was he
doing my procedure? Yeah, because the anesthesiologist, he just didn't have good anesthesia.
Oh.
And honestly, I should have just said, get control of the patient. And when you get control of the patient, I'm going to proceed. Until then, you need to get this patient under control.
Yeah.
And since then, I've done that several times, but at this point, I didn't. Trying to finish my procedure, I get it done. A week later, I see the patient. Yeah, I'm doing pretty well. Still have some numbness in my fingers. And I said, okay. A week later, he says, my numbness is worse than it was before surgery. I can't feel my 3 fingers.
Oh,
and I'm thinking to myself, oh my God, I cut the nerve.
Median nerve, right?
Oh yeah. And so a week later, I see him, and he says, it hasn't come back. I can't feel my fingers at all. And I'm really, and I can't get nerve studies at this point, because if you have a nerve injury, the nerve studies don't show something for a minimum of 4 to 6 weeks. So I said to him, we can wait, till 4 to 6 weeks after surgery, get nerve studies, see what's going on. We can go back in and explore it. And I'd never done anything like this before. In other words, cut anything bad during this kind of surgery. So he says to me, and he's this big guy, big mechanic, huge hands, just a big guy, which is part of the reason. He's so darn strong, during the procedure, we just couldn't get control of his arm.
Huh.
So he says, go in there, doc, let's see what's going on. So I go in there, and luckily, I guess I did the open procedure at this point. I just hadn't done a complete release. In other words, I'd gotten most of it, but the very end of the ligament hadn't been released. So I finished the release, and you could see how the nerve was just really compressed, because most of the ligament was released, and he was just pinched at this one area. So I finished the release, and he was fine. And he did great. In fact, he came back eventually for me to do his other hand. But yeah, that's, like I said, surgery can be, sometimes you just don't know. So, and it's how you handle it. From the get-go, I said, I don't think I cut anything, but I just don't know. So it's very important, in my opinion, if you think you have a complication, to kind of deal with it and take care of it.
Exactly. Wow. Well, that's good. That's good. Glad that nerve wasn't cut in that instance.
Yeah.
Never fun. Okay. Was there a specific person, Dr. Bruce, that inspired you to be an orthopedic surgeon?
Yeah. So I would say, as I said earlier, when I did my rotations, my orthopedic rotations, as a med student, those residents I worked with that first week, they were just really just inspirational guys. They were really the reason. And it was, there were a couple of them. There was Harry and Mark Figge. They were, I still remember him. Mark Figge actually still works at a hospital for special surgery in New York City. He's one of the big attendings there, which is a very famous orthopedic hospital in New York. They just they knew what they were doing. We could see they enjoyed that. They loved what they were doing,
Mm-hmm.
And they just inspired me. I said, this is something I can see myself doing for the rest of my life. And then during residency, when I did my residency at Hopkins, I worked with a couple of hand surgeons there. Same thing, just inspirational people, just really demanding. One of them in particular was very demanding. and accepted nothing short of excellence. And that's where I learned fear is a great motivator. Because he was definitely could be a intimidating person.
Okay.
But like I said, accepted nothing short of excellence. But they inspired me to go into hand surgery. Andy Weiland and Russ Moore. Andy Weiland actually went on to become the president of the American Academy of Orthopedic Surgeons, as well as the American Society for Surgery of the Hand. So two of the big societies that many hand surgeons belong to. And they were just, these are the kind of people that I would consider my mentors, and really caused me to really think about going into orthopedic surgery and hand surgery.
Interesting. And so they're still around to this day.
Yeah. I think Andy Weiland just retired. He's probably in his late 70s or 80 at this point. And Russ Moore, I think he's in his 70s. So I think they've retired at this point. But yeah, they're still alive. And I see them. I used to see them every so often. I don't see them as much anymore. So.
Okay. And what, if there are any resources, what resources would you recommend? Like if there was anyone out there that was interested in learning more about the field of orthopedic surgery and they wanted to explore it further, what would you suggest those people do?
Yeah, I mean, obviously Google's a great resource. Dr. Google always can give you answers. I see patients every day. Hey, well, I don't know. Dr. Google told me this. I see that a lot.
Yeah.
Unfortunately, Dr. Google doesn't really have good context. But I do agree that I like my patients to be informed. And so I don't discourage them from using Google at all. In fact, if anything, I encourage them to use Google. It's just that sometimes they lose context from what they're from looking at a Google search. But the American Academy of Orthopedic Surgeons website has tons of information on it where you can learn about anything in orthopedics. There's the American Society for Surgery of the Hand, same thing, a website. There's also so it's ASSH, American Society for Surgery of the Hand, and then there's American Society for Hand Surgery. ASHS, American Society for Hand Surgery. That's another. Those are both two big hand societies, and they both have lots of information on the websites about hand surgery. And you certainly could. People, couldn't go wrong from using any of those websites.
Okay, and they were both .com or .org. Yeah,
I think it's ASSH.org, American Society for Surgery of the Hand.org. And American Society for Hand Surgery, I don't remember what that is. I'm actually not a member of that, but I know plenty of really good hand surgeons that are, and they have meetings. I've just not been to one of their meetings, but I have been. I go to the Hand Society meeting or ASSH meeting almost every year.
Okay, awesome, perfect. Finally, Dr. Bruce Wolock, where can people find out more about you and what you do, and if you have any educational materials, or are you just focused just in the surgery area? I was just going to give you the opportunity if you wanted to learn more about you, if there was
Sure.
like a website or
yeah. I mean, my company website, Towson Orthopedics, I think it's towsonortho.com. There's lots of information there. You can look at all the docs in my group. I mean, we have over 20, 25 providers or physicians and PAs, nurse practitioners in our group. Lots of educational material there, bios and all the docs. So yeah, Towson Orthopedics or towsonortho.com, I think is the website.
TALSON?
TOWSON, Towson.
Oh,
Ortho, TOWSON, Ortho, ORTHO.com.
Got it.
And then, like I said, there's lots of information there.
Okay. Well, that's pretty straightforward to the point. So guys, you heard it right here on the Making Magic podcast. You could check them out at those links. Those links will also be in the show notes. If this magical field piques your interest at all, it really takes dedication and persistence and creativity to be in this kind of field. That's what I'm getting from this conversation based on everything that you said. I think anything in the medical field, if you want to take it that far, you really got to be passionate about it first, and you got to be dedicated to the school part, the university, and then the the extra training, and probably you go to like yearly training, or every X amount of months, you probably have different courses or something. I would assume that you go to stay up on par.
Yeah, I mean, we're required, I think, to have 50 continuing education credits or 50 hours of continuing education. I think every 2 years, maybe something like that.
Okay.
But I go to the Hand Society meeting, as I mentioned, almost every year, and then there's various tests. I usually take an exam once a year. It's a written exam that I usually take, and then there's other courses we can go to. And then, as an orthopedic surgeon, to be board certified, you have to recertify every 10 years. And so same thing for that. You actually, depending on how you do it, the way I'm doing is I have to take a test every year for 5 years. And for the first 5 years, you just have to get your certification credits. For the last 5 years, you have to take a shorter test every year for 5 years. So yeah, there's plenty of educational stuff that we do every year. It's required. And I actually don't find it that difficult. And I it's a field I've chosen. I kind of like, learning about what I'm doing.
Sure. Yeah. It's been said that if you really truly like what you do, you won't ever work a day in your life. So
right.
Obviously this is a field that you're really drawn to and that you enjoy. And that's good, because people need to be deep steeped in their passions and to get some satisfaction out of their life. And that's why I wanted to bring you on, just to kind of show people that even though this is a show about creativity and I bring on a lot of artists and things, you don't have to be an artist or a graphic designer or a performer or a prop maker to still exercise creativity in your field. And Dr. Bruce, I think you've demonstrated that you are capable of, and everybody else, especially that's on your team, with doing these incredibly magical arm reattachment, limb reattachment surgeries. It's a character trait that you all share. So thank you so much, Dr. Bruce Wolock, for taking the time out of your evening to jump on the Making Magic podcast.
Yeah. Thank you, Shaun. Really appreciate your having me.
Absolutely. And you guys have been watching and listening to another episode of the Making Magic podcast. Hopefully you guys have been getting a lot of value out of this episode. And if you have, feel free to follow the show, drop the show a nice review. If you're listening to one of the popular podcast apps, or if you're watching here on YouTube, give this video a thumbs up, click the notification bell, and subscribe. You guys know what to do. I don't even have to say this, but I'm saying it anyways. So I want to thank you all again so much for joining us. And this is Shaun J with Dr. Bruce Wolock here, and we'll see you guys on the next one.